Dr. INTAN ZARIZA binti Hussain, our fellow in Head and Neck Radiology, Hospital Kuala Lumpur. And Dr. INTAN obtained her medical degree from Indonesia, followed by a Master in Radiology from University Kebangsaan Malaysia. And today, she will talk about head and neck infection. So we'll welcome Dr. INTAN ZARIZA.
Assalamualaikum and good morning everyone. I am Dr. INTAN. Today I will be giving a short presentation on imaging in head and neck infection. At the end of this presentation, I hope we will be more aware of the importance of the anatomy and how relevant it is to the understanding of head and neck imaging, particularly related to infection. The objective of my talk today is to discuss the relevant anatomy related to neck infections. Then we will be talking about some of the common deep neck infections. We will also touch base on some unusual neck infections. And finally, we will discuss the complications of neck infections. Suppurative neck infections are associated with serious and life-threatening complications. It is very important to understand the anatomy and the different routes of infection spread to be able to address these infections. The neck is divided into compartments based on fascia. We have the superficial cervical fascia and the deep cervical fascia. The deep cervical fascia is further divided into superficial, middle, and deep layers. These spaces will form a series of cylindrical compartments that extend longitudinally from the base of skull to the mediastinum. And in between these facial spaces, we also have the interfacial spaces. First, we have the superficial cervical fascia. It is the outermost covering of our neck. It is composed of subcutaneous tissues that encircle the neck like a collar. It encircles a deep fascia. And components of the superficial cervical fascia are platysma and muscles of facial expressions, the subcutaneous veins, nerves, and fat, as well as superficial lymph nodes. And then we'll have a look at the deep cervical fascia. We'll talk about the superficial layer of the deep cervical fascia first. Let's see a cross-sectional cut across the suprahyoid neck. A very important ligament is the nuchal ligament. This yellow structure here is located posterior-centrally. It extends from the occipital protuberance inferiorly to the tip of the spinous process of C7 vertebra. Arising from the nuchal ligament, we have the superficial layer of the deep cervical fascia. Other name of this fascia will be the investing fascia. As it extends anterolaterally, this fascia will split to surround some structures, further defining the different compartments. It will split around the sternocleidomastoid muscle, and then the parotid gland defining the parotid space, and it will split again around the masseter and pterygoid muscles, defining the masticator space. And in the infrahyoid neck cross-section, the superficial layer also surrounds the trapezius muscle posteriorly, the sternocleidomastoid muscle laterally, and the strap muscles anteriorly. Next, we have the middle layer of the deep cervical fascia, also known as the buccopharyngeal fascia. This will define the pharyngeal mucosal space. And you can see here in the left side image, in blue, as it comes around the pharyngeal structure, it will define the oral cavity, while in the infrahyoid neck in the right image, the middle layer of the deep cervical fascia, which is in yellow, it surrounds the laryngeal structures defining the visceral space. And as for the deep layer of the deep cervical fascia, it extends from the skull base to the superior mediastinum at T4 level. The deep layer of the deep cervical fascia starts similarly like the superficial layer of the deep cervical fascia from the nuchal ligament at the posterior aspect. It will extend and surround the paravertebral muscles, defining the perivertebral space, and as it extends anteriorly, it will split into the alar fascia and the prevertebral fascia, as annotated in blue. And in between the alar and prevertebral fascia, we have a small space which is called the danger space. We will further discuss about this space later. In between the prevertebral fascia and the vertebral column, there is a space called the prevertebral space containing the prevertebral muscles. So you can see here in the schematic drawing that This fascia will form cylindrical compartments that will extend from the skull base all the way to the superior mediastinum. Centrally in the neck, we have the pharyngeal mucosal space, which is represented here in orange, which is defined by the buccopharyngeal fascia or the middle layer of the deep cervical fascia. It extends inferiorly at the infrahyoid level as the visceral space and contain the trachea and esophagus. The other important space is the danger space, which is behind the pharyngeal mucosal space and the prevertebral space. You will see here in the cross-sectional image as a little space between the pharyngeal mucosal space represented in green and the prevertebral space represented in blue. So the danger space is a little space here in between these two spaces. It is called an interfacial space as it does not have its own fascia. Another interfacial space that we can see in the diagram is the parapharyngeal space, which is in red. It is formed by the defining fascia of the surrounding structures. Another two spaces we see here is the masticator and the parotid spaces, which are defined by the superficial layer of the deep cervical fascia. Another interfacial space that we will be discussing is the submandibular space here, which is below the mandible. Deep neck infections most commonly seen in pediatric populations are either secondary to tonsillitis or pharyngitis. In adult populations, they are usually related to odontogenic infections. Other causes include otitis media, sinusitis, trauma, IV drug use, diabetes, or immunosuppression. Sometimes there can be no identifiable source, and in this case, they are idiopathic. In a retrospective analysis of 117 patients treated for deep neck infections, a vast majority is in the peritonsilary regions, that's peritonsillar abscess, almost 50%, less so in the retropharyngeal region, 22%. Other regions are submandibular, 14%, and buccal and parapharyngeal infections, 11% and 2% respectively. Before we go further, let's discuss a very important concept, the difference between phlegmon and abscess. Pathologically, a phlegmon is an infected tissue or cellulitis without area of necrosis. In contrast, an abscess will have a drainable cavity of infected debris. On imaging, phlegmon will appear as low attenuation region with poorly defined margins, while abscess will appear as fluid attenuation lesion with rim enhancement. Finally, the treatment for these two pathologies are different. Phlegmon requires supportive care and antibiotics, while abscess, depending on the size and site, will require surgical drainage on top of supportive care and antibiotics. In terms of imaging, it has very good sensitivity, up to 100% in detecting a phlegmon or an abscess. However, it can be challenging to differentiate between these two with specificity on imaging ranging from 45 to 82%. Some examples of a phlegmon and abscess. You can see in these patients who presented with fever and neck pain and difficulty in breathing. You can see here in this patient, there is an ill-defined area of low attenuation located behind the pharynx. This is a retropharyngeal phlegmon. And in this other patient, you can see that the left palatine tonsil is larger, and I hope you can see there is a subtle ill-defined hypodense area within. This is a peritonsillar phlegmon. Subsequently, in the follow-up imaging of these two patients, you can see there is an abscess formation in the right retropharyngeal region. There is a well-defined rim-enhancing collection in the retropharyngeal region, and this is a retropharyngeal abscess. And in the next image here of the other patient, we can see similarly there is a rim-enhancing collection at the peritonsillar region. This is a peritonsillar abscess. On this note, let's discuss briefly on the tonsillar anatomy. The palatine tonsil are located in the tonsillar fascia. Here we can see that the palatine tonsil is enclosed within a well-defined capsule. Anteriorly, forming the anterior pillar is the palatoglossus muscle, and posteriorly, forming the posterior pillar is the palatopharyngeal muscle. Laterally, we have the pharyngeal constrictor muscle, and the peritonsillar space is the space in between the pharyngeal constrictor muscle and the tonsillar capsule. On cross-sectional imaging, we can see that this is the palatine tonsil, and anterior to it, this hypointense structure here is the palatoglossus muscle forming the anterior pillar of the tonsil, and posteriorly we have the palatopharyngeal muscle forming the posterior arch, and laterally this is a pharyngeal constrictor muscle. On imaging, usually the peritonsillar space is not well defined, but it is a space that is most frequently involved in adjacent infections. So once infection forms in this space, we get what is called a peritonsillar abscess or Quincy's abscess. Here we have a well-defined rim enhancing collection between the left palatine tonsil and the pharyngeal constrictor muscles within the peritonsillar space. Similarly, on coronal, you can see that there is bulging of the left palatine tonsil, and this is the rim enhancing collection between the tonsil and the pharyngeal constrictor muscle. For our clinical colleagues, they will only be able to see a bulge and swelling at the posterior aspect of the soft palate. There will also be evidence of an inflamed palatine tonsil and displacement of the uvula. Now moving forward from the peritonsillar infection to infections of the oral cavity. But first, let's discuss on the oral cavity anatomy and some important pathways of infection spread. An important structure located in the oral cavity is the mylohyoid muscle. This muscle can be identified on imaging as a cup shape or a sling across the floor of the mouth. It attaches on the inner cortex of the mandible bilaterally. And then we have the anterior belly of the digastric muscles at the floor of the mouth, which further supports the mylohyoid muscle. This mylohyoid muscle will define two spaces in the floor of the mouth, which is the submandibular space and the sublingual space. The sublingual space, as the name suggests, is located below the tongue, superior to the mylohyoid muscle. So this is the mylohyoid muscle here, and superior to it we have the sublingual space. And below the mylohyoid muscle, we have the submandibular space, which is located inferior to the mandible. There is no connection between the sublingual and the submandibular spaces anteriorly. However, posteriorly, there is a gap in the mylohyoid muscle known as the buccopharyngeal gap. This gap allows spread of infection from the sublingual space either to the submandibular space or posteriorly to the pharyngeal mucosal space. Here is an example of a patient with a sublingual abscess. There is a well-defined rim enhancing collection in the sublingual space. It is above the level of the mylohyoid muscle. In this image here on the right, it is showing how this infection is mostly related to odontogenic infections. Any odontogenic infections will perforate the weak wall of the buccal cortex of the mandible into the sublingual space, forming collection above the mylohyoid muscle. Compare this to a different patient. There is a peripherally enhancing collection, but located below the mylohyoid muscle. And this is an abscess in the submandibular space. So this is the mylohyoid muscle, and the collection is below the mylohyoid muscle. And the image here on the right is showing how an odontogenic infection causes a submandibular infection. And finally, what you can have as a complication of an odontogenic infection, you can have infection spreading posteriorly to the masticator space. In this example, there is a multiloculated rim enhancing collection in the muscles of mastication involving the pterygoid muscle as well as the masseter muscles. So an odontogenic infection can result in sublingual or submandibular or masticator space infection. The question that presents itself is what defines these different compartments? Why some infection goes to the sublingual space while others go to the submandibular space or masticator space? The defining factor is what we call the mylohyoid line. It is basically the line at which the mylohyoid will insert itself at the inner aspect of the mandible. The relation of the apex of the teeth correlate with the preferential spread of infection. If the apex of the tooth is above the mylohyoid line here, infection will preferentially spread to the sublingual space. Compared to the apex of the tooth, which is below the mylohyoid line, infection will preferentially spread to the submandibular space. And if infection is from the posterior tooth, it will spread to the masticated space posteriorly. Ludwig's angina is another very important and luckily quite rarely encountered. It is infection involving both the submandibular and sublingual spaces. There is no lymphatic involvement and generally without abscess formation, only cellulitis. 70% is associated with concomitant dental infection. In this example, in the coronal reformatted images, we can see there is ill-defined inflammation in the sublingual spaces bilaterally. And as we move posteriorly, we can see the inflammation spreads through the buccopharyngeal gap into the submandibular spaces. And there is also extension of the inflammation along the parapharyngeal wall. The patient is intubated here in the axial image, but you can see that there is extensive soft tissue swelling within the parapharyngeal space and complicated with severe airway narrowing. Moving on to the next compartment, we will discuss the compartment behind the pharynx, which is the retropharyngeal space. The retropharyngeal space is an interfacial space bordered anteriorly by the buccopharyngeal fascia, which is here represented in green, and posteriorly by the alar fascia, represented in pink here. It is filled with fat and connective tissue and does not have a fascia of its own. On imaging, the retropharyngeal space will extend from the skull base anterior to the vertebral column behind the pharynx and typically ends around T2 level. On axial section, the retropharyngeal space is defined in yellow here, bounded posteriorly and laterally by the alar fascia and anteriorly by the buccopharyngeal fascia here. On imaging, the majority of retropharyngeal space infection is associated with upper respiratory tract infection, especially in pediatric population. Here is an example we have seen earlier. There is an ill-defined hypodensity in the retropharyngeal region and there is no clear abscess formation. This is in keeping with a retropharyngeal space phlegmon. 2 days later, this progresses to form a rim-enhancing collection, which is called the retropharyngeal abscess. Another common cause of retropharyngeal space abscess is as complication of procedures, for example, perforation of the pharyngeal or esophageal wall. And in this next example, we see an extensive retropharyngeal abscess related to this recent endoscopy procedure complicated by perforation of posterior pharyngeal wall. We can see in these images that this abscess spreads inferiorly all the way to the superior mediastinum around the trachea, the esophagus, as well as the great vessels. Management in this case needs to be more aggressive as it will unlikely respond to just supportive care and antibiotics. Surgeons will consider putting drainage catheter to drain the pus. Posterior to the retropharyngeal space, there is the danger space. It is located between the alar fascia anteriorly and the prevertebral fascia posteriorly. So it is this space here represented in blue in between the retropharyngeal space and the prevertebral space. It can be difficult to differentiate between the retropharyngeal space and the danger space on imaging. The only clue is the fact that infection will spread further inferiorly compared to the retropharyngeal space infection. Remember that I mentioned retropharyngeal space extend inferiorly to the level of the thoracic inlet at around T2 level. The danger space will extend more inferiorly and can reach until the level of the diaphragm. As you can see in this example here, there is a rim-enhancing collection within the danger space that extends from the base of the skull and inferiorly into the thorax and until the level of the diaphragm. Next, posterior to the danger space, we have the prevertebral space. It is defined anteriorly by the prevertebral fascia and posteriorly by the vertebral column. The infection in the prevertebral space are most commonly the complication of osteomyelitis of the vertebra, with infection spreading into the prevertebral space. Here you can see the sciatis changes, and in this example, there is prevertebral collection extending in the from C2 to C6 level. In this next image here, we can also see there is epidural abscess formation. On axial image, this is better defined, where we can see here we have rim enhancing collection within the longus colli and the longus capitis muscles, which is in the prevertebral space. This is in contrast with infection in the retropharyngeal space or danger space that usually spares the prevertebral muscle. Another interfacial space is the parapharyngeal space. This is also another quite dangerous space as it also extends throughout the suprahyoid and infrahyoid neck, and infection can extend into the mediastinum. The parapharyngeal space is this lunar-shaped area that is filled with fat located between these other spaces, namely the masticator space anteriorly, the parotid space laterally, the carotid and the prevertebral space posteriorly, and the pharyngeal mucosal space medially. Infection in the parapharyngeal space is typically related to infections arising from other compartments. We do not get infections that arise primarily from the parapharyngeal space. Typically, infection from the palatine tonsil that has spread to the parapharyngeal space, or infection from sinusitis or mastocytitis. Here in this example, there is a poorly defined inflammatory changes in the parapharyngeal space with presence of air pockets. This is secondary to a recent dental extraction with inflammatory changes in the parapharyngeal space. Compare it to the contralateral parapharyngeal space, where there is a well-defined fat space representing the normal parapharyngeal space. It can be quite confusing, so here we can see a comparison between the peritonsillar abscess and parapharyngeal infection or abscess. In this example here, you can see there is a rim-enhancing peritonsillar abscess next to the palatine tonsil. It is bounded laterally by the pharyngeal constrictor muscle. The parapharyngeal fat, which is posterolateral to it, is completely spared. In contrast, in this patient, there is infection of the parapharyngeal space, which is lateral to the pharyngeal constrictor muscle, filling up the entire parapharyngeal fat space. It is always helpful to compare it with the normal contralateral side. We have discussed the different compartments in the head and neck region and addressed some of the infections in these compartments. There are also other typically recurrent neck abscesses that we will encounter every now and then. And in these cases, we need to think about underlying congenital anomaly. So here are two different patients who presented with recurrent neck abscesses. The first patient, the abscess is located in the level of the tongue base, and in the second patient, it is located below the hyoid bone in the midline. These collections does not belong to other infections that we have discussed earlier. And in these two patients, the infections are related to persistent thyroglossal duct cysts, either the suprahyoid portion, at the tongue base, or at the level of the infrahyoid region as it extends to the thyroid gland. This is a different patient with unusual abscess. There is a large rim enhancing collection deep to the left sternocleidomastoid muscle, but lateral to the carotid arteries. This is nothing but an infected branchial cleft cyst. In this example is the second branchial cleft cyst. Occasionally, we can also get patients with infected third or fourth branchial cleft cyst in patients presenting with recurrent thyroiditis or abscess around the thyroid bag. Complications of neck infections can be very serious. It can spread to the mediastinum, causing mediastinitis. It can also cause vascular complications like Lemierre's syndrome or arterial complications like vasospasm, arteritis, or pseudoaneurysm. And finally, you can have cavernous sinus thrombosis. In the setting of prevertebral abscess, it can also spread into the spinal canal, causing epidural abscess. So we have seen this example earlier of a retropharyngeal abscess spreading into the mediastinum, causing mediastinitis. Lemierre's disease is infrequently seen, but we should be aware of it. It is thrombophlebitis of the internal or external jugular vein that is complicated by lung emboli, usually caused by Fusobacterium necrophorum. But any infection can be complicated by Lemierre syndrome. Here we have a collection in the left peritonsillar region. And if we have a closer look, there is evidence of thrombophlebitis of the adjacent branch of the external jugular vein, which is the retromandibular vein in this example. This is also further complicated by embolus to the lung, causing a cavitating lung lesion. Other vascular complications will be arterial complications. Here is an example of an esophageal perforation with extensive inflammation in the adjacent soft tissue. It is very important to note that the right common carotid artery here is markedly narrowed compared to the left common carotid artery. This could be either due to vasospasm or through arteritis. The only way to tell them apart is on follow-up imaging, where artery will be back to normal in vasospasm. Another complication is pseudoaneurysm, as seen in this example of pseudoaneurysm in the carotid artery at the skull base. This was a complication of skull base osteomyelitis with abscess in the prevertebral muscles. The final complication that I would like to address is cavernous sinus thrombosis. This is an example of extensive bilateral masticator spaces abscess, which is complicated by cavernous sinus thrombosis. As you can see, there is outward bulging of the right cavernous sinus, more compared to the left side, with poorly defined filling defects within the right cavernous sinuses, in contrast to the normal cavernous. So in summary, we have discussed different cervical fascia that divides different compartments within the neck region that will define how infection forms and how it spreads. We have also seen typical appearances of phlegmon versus abscesses. We have discussed unusual and recurrent neck abscesses, in which we may need to consider underlying congenital abnormalities. And finally, we have discussed complications of neck infections. That's all from me. Thank you.
Thank you, Dr. Intan. So, following this will be the Q&A session for head and neck infection. So, okay. So, the first questions directed to Dr. Intan is, Dr. Intan, is phlegmon same as non-liquefied abscess from Fu?
Hi, good morning. Thank you for the question, Fu. Okay, so is phlegmon same as non-liquefied abscess? Phlegmon is actually non-specific inflammation of the soft tissue, or more commonly known as cellulitis lah. So it does not usually have a proper boundary. So and in non-liquefied abscess, even though it can, even though a phlegmon can progress to an abscess, it does not usually progress to an abscess. It does not necessarily progress to an abscess. So it's basically just edema of the soft tissue. Sometimes it can resolve with antibiotics and all that, and supportive care. So what you will see is basically just ill-defined area of hypodensity with fluid within the spaces. So you can see the muscles swollen and hypotense, but you don't see a proper rim enhancing lesion or an enhancing lesion within. And we have also seen some cases where we see phlegmon and fluid tracking in the danger space, or sometimes in the retropharyngeal space, even though there is no rim enhancement or no proper boundary. When the surgeons went in to drain, these fluids are actually passed So on CT, it can get quite confusing. You may see fluid attenuation, which appears as edema on CT, but it's actually purulent material. Yeah, I think that's all for the first question.
For the second question, Dr. Intan, how to differentiate between phlegmon and edema in the retropharyngeal space?
So like I said just now, phlegmon is basically cellulitis. So it is swelling and hypodensity of the involved structures, which are the muscles, subcutaneous fat, or overlying skin. And edema, we will see fluid. These two can coexist together, and phlegmon and edema are usually coexist together.
Okay, Dr. Intan, that's all for now. The rest, if there is any further questions, they will direct it in the chat box and you can answer within the chat box. Thank you.